Hello, everyone. Good morning, good afternoon, good evening. It is a pleasure to welcome you to this global webinar for the WHO DHIS2 packages for HIV, tuberculosis, hepatitis, and sexually transmitted infections. My name is Babis Sismanidis. I am the team lead here at the department for these 4 disease areas, responsible for strengthening surveillance and programmatic use of data. It is a pleasure to welcome you all once again, and we are excited about the content we are about to share with you. So just a couple of words to set the tone a little bit. The work on strengthening surveillance and digitization of data to facilitate data use is a long-standing priority at WHO based on our understanding of country needs. And we have been doing a lot of work in collaboration with University of Oslo, that is a collaborating center, as well as our partners, funding agencies, the Global Fund and the Gates Foundation, as well as collaboration with many disease programs from countries around the world. So this is ongoing work that I would say has started in earnest really about 5 to 6 years ago, and we are now in a position to update you with the latest available products. There's been a few versions of these WHO DHIS2 packages. The products that you will see now that cover the 4 disease areas are the latest available ones, and they are all in line with the latest surveillance guidance that has come out from WHO in our department. Okay, so we will start with some housekeeping information that will be given to us by Shona. Shona?
Thank you, Babis. Hello, everyone. My name is Shona Dalal. I work in Babis's team on surveillance, mainly focusing on HIV. Today in this webinar, we have interpretation. You can find the bottom at the circle at the bottom of your screen for either French, Russian, or Spanish. And so you can choose the language that you prefer. For the questions in chat, we'd prefer for the Q&A that there's a little icon at the bottom that says Q&A. So please put your questions regarding the topic and the presentations in the Q&A. But use the chat feature if you have any issues regarding IT or the interpretation or logistics. So that will be helpful for us. And just to let you know that this session is going to be recorded. So your attendance here is consent to be recorded, and the recordings will be shared afterwards and available online. We will also post a feedback survey about 10 minutes before the end. You'll see a screen pop up on your computer, and you can then fill in the few, I think it's 3 questions there. I think that's it from me. Over to you, Babis.
Thank you, Shona. I should also say we will try our best to keep to times and really have a Q&A session at the end of this webinar. However, I would encourage you all, as you have the questions, for you to be posting them on the Q&A room, as Shona has explained, and we will be responding to those real time. So in case we run over with some of the presentations and the panel discussion, we will definitely be responding to these questions that you will be posting live. Okay, so let's start first with a presentation from Anne. Anne will be setting the scene and will be discussing about health management information systems and the digitization agenda. Anne, the floor is yours.
Thank you, Babis. Good afternoon, good evening, good morning, colleagues. So I am overseeing the as Babis mentioned, the health information systems, and I'm working at the Department of Data and Digital Analytics and AI, a new structure in WHO HQ. Next, please. So I will start with this very overall framework that we just finished the assessment, and we have 145 countries responded to this, where we look at the data structures and the digital implementations of these data systems. And we highlight here is the roles of the data that fitting in for the health information systems, and also the data that coming from the health facilities across the population data referring to the service, to the surveillance and some of the survey works, to the vital statistic that look into the mortality, looking into the denominators, the birth and the death. The facility-based data systems of that, a lot of it is on the service data, but also lots of it is also look at the capacity of the facility and the quality of the service, and what are the input system, the human resource, the logistics, and the financial monitoring, and the capacity to use the data at different level for different purposes, and the overarching crossing of data governance and digital implementations. Next, please. So I'm just very quick touch on this too, because it's interused between the HMIS and the IHIS. The IHIS standing for routine, because majority of the data that feed into the health management information system, especially at subnational level, are coming from the routine data. So it supports the monitoring, the planning, but also more and more we focus on is the use of the data. And I think today the sessions, a lot of that will show how the data used at subnational level can actually have an impact in strengthen the programs overall. And then the cross-cutting, one of the important of it is data quality, the capacity to compare the data across a program and to look at it from the completeness. So data should be collected once, should be reused by different program, by different facility, by different purpose. And that's how we're trying to reduce the burdens of reporting. One of the key themes that come up a lot recently, especially on the digital health landscape, is how we're going to bring all this reporting system together and bring it into one simple platform so we can harmonize and standardize all the data we collect. We have and the toolkit we present today is also look at how we can standardize analysis and strengthening the use of that at all different levels as well. Next, please. I just touched very quickly on this WHO flagship that has been the coordinated work across all different programs, and we are sitting here. This is the work in the last 6 years to look at different programs, the needs, and collect the data, starting with the M&E framework to go into further into the case base, how we do it together. But then we also look at from the cross-cutting perspective, the health statistic report, the health management, the health facility management report, how we can use it and make use of the data that we collect daily. So we do not have to submit up only, but we can use it on the daily basis, on the real time, and also on a routine basis. Next, please. Just highlight here is that the key part, we have a TB, HIV, STI, hepatitis, and case-based surveillance. These are the work that used to be in the different systems, and now we can look at it together with the mortality, together with the logistic, the lab system. We can do a lot more with the data we have, and I think this is why we work together on this purpose and why we have this webinar. Next. So going highlights on everybody talking about now the two things, the digital health and the AI. I put the AI aside and look at the digital health. Without the proper structure on the standard of the data, the capacity to share and understand the data, then it will be very difficult to digitalize it. So we look at the framework of the toolkits that I presented earlier, and then from there, we look at it, how we can digitalize it. And the SMART guideline would be the key points, and Oslo University pick it up and then translate into the package that it can be implemented in 80 countries. Next, please. So just the conclusions, we have a lot of systems that are available. We understand the need to bring the data together. We have the SMART guideline approach that standardizes the way data are structured, and then the translation of it into the DHIS2 package so that country can work together. But most importantly is how we can build the capacity in the country and how we can use it at all levels in the health system. And I will pass it on to the next speaker. Thank you.
Wonderful. Many thanks, Anne, for setting the scene. I will now ask Marek to take the floor and deliver the presentation on the content for TB. Marek, the floor is yours.
Thank you, Babis. And good afternoon, good morning, colleagues online. So my name is Marek Lally, and I will present now on the TB surveillance guidance that was released in 2024 and the associated WHO DHIS2 TB surveillance packages. So the new TB surveillance guidance, which I mentioned was published in 2024, is an update to the 2013 definitions and reporting framework for TB, which was quite outdated. Since then, we had lessons learned from more than 100 epidemiological reviews and assessments of TB surveillance systems, which really informed a lot of the update to this guidance. We also had to align with new updated guidelines on diagnosis, treatment, and prevention, and update a more robust surveillance of DRTB following a 2020 consultation. We also took the opportunity to provide more of a focus on digital case-based surveillance because since 2013, there's been a lot of work done in this space and a lot more countries using digital case-based surveillance for TB. And then we also made an update in order to accommodate the increasing demand of more timely TB data. So the guidance is published at the link and QR code here on the slide. We have the core guidance plus 6 web annexes. All of these documents are available in all of the 6 UN languages, and we also have a summary slide set that helps the digestibility of the information in the guidance. Next slide, please. So just a quick overview of what's new in this guidance. It's now a more consolidated and comprehensive package on TB surveillance, which brings together not just the guidance, but also other related WHO products. So this is a big change compared to the definitions and reporting framework since that was published in 2013. We made some minor updates to terminology, but these updates are just language. It doesn't have any implications on the definitions of these terms. Most of the indicators that are included in the guidance are what we are used to using and analyzing in the TB space. However, we did make a few key updates, one of which is to now monitor treatment initiation, and those who have not started treatment, the reasons for that, whether they died or were lost to follow-up before treatment initiation. We have a new way to disaggregate treatment outcomes, this now by duration of treatment, so treatment regimen, rather than case type. And now we also have a new indicator for case outcomes, which looks at what happened to everyone who was diagnosed with TB, regardless if they started treatment. There's a more detailed explanation of the indicators in the core guidance, including their disaggregation and calculations. And you'll see that we're now making a distinction between the core indicators and their disaggregations and reporting frequency that are for all countries versus those with a digital case-based surveillance in place. And in Chapter 5, we have the specifications of all of the core data items that should be collected or that are needed in order to calculate the core indicators. We now have a guidance on how to establish or strengthen case-based digital surveillance, and we also provide a framework for assessing data quality. Next slide. So this is just a very high-level picture of the core indicators and the reporting frequency that are included in the guidance. So we have those, as I mentioned, for all countries, irrespective of the type of surveillance, and then those for countries with the case-based digital surveillance in place. And I just want to draw your attention to the total number of indicators for all countries. And we see that we have 3 different reporting frequencies. We have one indicator that we're recommending for rapid reporting. So that's either weekly or monthly, depending on the system that you have in place. And that indicator is the provisional total number of new episodes of TB notified in that period. We then have the usual quarterly and annual reporting, which we're now calling regular and consolidated. And you'll see that we have a different number of indicators for each of those. Less indicators to be reported quarterly. And the reason why we did this is to try to alleviate a bit of the burden on reporting of data at the quarterly interval. And then you can see that we have the indicators categorized in these 4 categories. We have indicators for people who are diagnosed with TB, a set of indicators for the coverage of testing of drug resistance and the results from those tests, and then finally a set of indicators for people who are treated for TB disease. And for countries with a case-based digital surveillance system, we have some additional recommended indicators and some optional indicators that are related to rapid testing, contact investigation, and prevention. Next slide. Chapter 6, just to put a little spotlight on it, is covering digital surveillance. So we know that TB data are not just generated at the health facility, but they're also being generated at the lab, at the household and community, all along the pathway of prevention and care. And so the vision is to have a consolidated surveillance database that brings together all of these data into one place using a system that fits within the public health surveillance architecture. So this chapter provides a clear description of the advantages of case-based digital surveillance systems and how they can be used in practice, and with 8 case studies of national experience in establishing or enhancing case-based digital TB surveillance in their settings. We also provide a description of the WHO digital packages for TB surveillance, which is what we'll move on to now. Next slide, please. So we've developed the WHO DHIS2 metadata packages for TB surveillance, which are available for aggregate data or case-based data. And these are fully aligned with our global standards in the TB surveillance guidance. So the recommended indicators, disaggregations, data elements, and workflows are all captured in this metadata package. So essentially, this is a digitization of the WHO surveillance guidance into a DHIS2 metadata package that's a ready-made solution that you can adopt for local installation and use, configure it appropriately for the setting, and then use for your surveillance system. Next slide. This is a quick snapshot of the difference between the aggregate system and case-based system. It might seem obvious. The only difference here is the type of data that are being entered. So for the aggregate system, you're still relying on the paper registers, and you'll still have to manually aggregate the data, but then you'll enter them into the digital quarterly report form in DHIS2. For case-based, you're entering individual level data, so data on each and every person that you're entering into DHIS2. And then the system will do the aggregation. So beyond that, the systems are the same. The data, the indicators are the same, and the dashboards for data visualization are exactly the same. Next. Focusing a bit more on the case-based package. So the case-based package is organized across 5 stages. We have the registration of presumptive TB cases. We have the laboratory testing and results, diagnosis and notification, treatment, and finally outcomes. And through these stages, we track the patients through the health system. So the DHIS2 workflow is based on the routine patient flow that we see on the lower half of this slide. Next slide. We have an additional package, which is the household contact tracing and TB prevention module, which we see here in green. This is a separate module that acts as a kind of expansion pack that can link with the TB case surveillance module, which we see here in blue. And the household contact tracing module follows people through that pathway of screening and prevention. And I just want to point out very quickly the glowing green arrows, because this is showing how the 2 systems link. So once you notify a person with bacteriology confirmed pulmonary TB, we can then register those contacts automatically in the household contact tracing module. And then in the screening and testing for active disease, depending on what the outcomes are there, then this person would then be fed into the surveillance module at the enrollment of presumptive TB case stage. Next slide, please. Taking it one step further, we can also think about interoperability with other systems that might be in place in the country. So in green here, let's say this is our DHIS2 routine surveillance with the contact tracing and prevention module installed. We can see how it can connect to other systems. So at the registration stage, it can connect to Prevent TB, which is a mobile application that's been developed here at WHO to support screening and prevention activities out in the community. And at the laboratory stage, there's the opportunity to connect with laboratory information systems or digital diagnostics such as GeneXpert, so that these data don't have to be manually entered into the surveillance system, but automatically pushed in. Next slide, please. Once the data gets entered into the system, there's a series of dashboards to help visualize all of these core indicators that are covered in the surveillance guidance and their disaggregations. And through these series of dashboards, it should really facilitate more comprehensive and routine analysis of TB data. And finally, for my last slide, I'm just going to point you towards Web Annex F, which reports on the findings from an assessment that we carried out on the implementation of the DHIS2 case-based TB surveillance packages in 5 countries, including identifying best practices in these countries that helped with a successful implementation. So I would encourage you to look at this and consider these best practices for implementing in your own setting. And with that, I'll hand over back to Babis. Thank you.
Many thanks, Marek, for the TB content. May I now please ask Shona to cover HIV, hepatitis, and STIs. Shona, the floor is yours.
Thank you, Babis, and good afternoon, good morning, colleagues, wherever you are. So today you've heard the details about TB, and I'll cover some of those for HIV, hepatitis, and STIs. The process, as you can imagine, is quite similar. So we have new strategic information guidelines on HIV, hepatitis, and STIs that are responding to current and future data needs. These are shown here on the right. And they focus on several strategic information priorities. The first is a greater focus on impact with more individual level granular data to fill gaps with a results chain that links services provided to reduced incidence and mortality. A second is building monitoring systems for stronger person-centered longitudinal monitoring, because particularly for HIV, people are on treatment for life. And once they are, then we need to be able to engage them, link them in between other services, and retain them in care. The third is the digitization of health data, which makes the interconnection of different data sources possible. And this enables better patient management, service delivery, and program performance. And the last is strengthening data use from all sources, because we know that patients who come into the clinic are only some of those and others may not make it in. So using population-based surveys, modeling, looking at quality of care measures and community-led monitoring are also important to accurately monitor the response to all these epidemics. So the key components of our guidelines are for HIV, there are 22 key data recommendations. They focus on individual level data to support prevention, testing, and treatment programs, the better integration of TB, STIs, viral hepatitis, and cervical cancer, and the use of routine data for HIV surveillance to track the epidemic. So that includes looking at approaches to measure HIV incidence. And finally, to build a secure, interoperable digital data system. One of the underlying principles for the guidelines is the use of a minimum data set that captures key events in an individual's interaction with the health system. And I'll show you some examples to come. We have priority indicators. 25 of these are deemed to be core, and 80 of those are priorities, but are not as essential as the core indicators. And then again, there are specific chapters on strengthening data use from all levels and at all sources, as I've already mentioned. So focusing on the minimum data set for HIV case surveillance, each event starts with an HIV diagnosis and goes through pretreatment, disease progression, and finally ends in mortality. And as part of these, there are certain data elements that are necessary to collect for each stage. So for example, for HIV testing, you need the test date and the result. And then subsequently for all the different parts of disease progression. There's a separate section here for pregnant women to look at vertical transmission and to be able to calculate those indicators. We also, for the first time, have a minimum data set on HIV prevention. It's been long a practice for treatment, and prevention is challenging for HIV because people can start and stop prevention depending on their level of risk. So here are some examples. We've detailed each intervention and then the minimum data set that should be required in all national surveillance systems for HIV to capture this information accurately and to be able to then calculate indicators to monitor the delivery of HIV prevention. So for example, for PrEP here, it should include the date that PrEP was prescribed, the product that was prescribed, the volume that it was given, and then the date that they may have a follow-up appointment. We also detail longitudinal monitoring. So this is for treatment for over the life course of an individual living with HIV. It starts from the first clinical encounter, and we detail the data that needs to be extracted and analyzed, and similarly across periodic intervals, whether that's 6 months, 12 months, or 18 months, and it depends on how stable that patient is on ART and how they are doing. And so these are data that need to be captured periodically. So now moving to the standardized DHIS2 trackers, I'll focus here on the individual level data trackers, but there are also aggregate packages, as you heard from Marek on TB, and both of those are available from the DHIS2 website. So for HIV, we have 2 trackers. One is for case surveillance, which starts once an individual is diagnosed with HIV, and the second is for HIV prevention. Both of them are consistent with our WHO guidance, and the intention is that they should improve the quality of care for individuals either receiving treatment or prevention services, to improve the routine monitoring of facility data, and to then aid in the national response. There are dashboards that speak to multiple perspectives, whether national, subnational. There are standard analyses such as the 95, 95, 95 global AIDS targets, and there are disaggregated analyses of essential cascade indicators. So for prevention, the tracker package covers all the different prevention interventions, including testing, PrEP, PEP, opioid agonist maintenance therapy, needle syringe programs, and we also have viral hepatitis testing and STI testing and treatment for syphilis and gonorrhea. And there's also VMMC. And the nice thing about the packages is that they are modular, flexible, and customizable so that they can be adapted to the country context and what makes sense for each individual setting. So just to walk through some of the examples. So this is an example of the testing services. Across the top are the key WHO indicators. I'll just point out one of them, which is here on the right, the HTS linkage to prevention. This indicator requires every single prevention data element for all interventions to be recorded, and often this is poor. So this is something that we would encourage you to look at as an area to improve, because for people at elevated risk of HIV, we want to make sure that they receive prevention services. Once a person tests HIV positive, the records from this individual can then move into the case surveillance tracker. They can both be implemented together or separately, and this is then reduces the amount of reporting burden. We have ones for PrEP, as you can see here. You can see that there are subnational analyses, either by geography or facility. We have, this is the one on STIs, which covers 3 main parts of STIs. There's syphilis testing, there's gonorrhea testing, positivity and treatment, and then the presence of STI syndrome and repeated diagnosis of syndrome. And then there are various age and gender disaggregations. For viral hepatitis, we cover hepatitis testing for clients attending HIV prevention services. It includes hepatitis B test coverage, positivity rates, and the same for hepatitis C. For cervical cancer, the focus is on women and girls living with HIV because they have a 6-fold higher risk of getting cervical cancer. So the start point here on the top left is women living with HIV who are attending care and treatment services, and then through the cascade of whether they were screened, whether they received a diagnosis for precancer or invasive cancer, and then whether they were treated or not. So in conclusion, strengthening routine individual level data systems really improves national capacity to monitor and respond to health needs in real time at both local and national levels. It improves the quality of care, of surveillance, and program performance and impact. It's sustainable and scalable, increases linkage capacity across different data systems, facilitates longitudinal records and patient access to their own records for continuity of care. It helps with improving integration across related infections, but it's important to note that all these improvements will be progressive. Those building blocks, those essential data elements are needed to be able to calculate any of these indicators. So these digital tools incorporate all these different aspects of WHO guidance, the clinical guidance, the data guidance, so that they can be implemented with fidelity. And I'll just close by saying that even in reduced funding environments that we have today across global health, ensuring routine surveillance systems remain functional and adequately resourced is going to be essential to monitor the response to these conditions in the future. Thank you.
Excellent. Many thanks for that, Shona. We will now move on to the live demonstrations for the TB and HIV tracker. I believe we will hear from Yuri first, who will walk us through the TB tracker, followed by Stefano, who will walk us through the HIV trackers. Yuri, the floor is yours.
Good afternoon, everyone. My name is Yuri Robichev, and I'm working as an implementer at the University of Oslo, supporting the TB program with the development of the TB surveillance packages. Hope you can hear me well. Babis, can you confirm it?
Yes, it's all good.
Yeah, thank you. So I will share my screen now and give you a quick guide of what we have developed together with the team at WHO. So what you see on the screens is the login to the DHIS2 instance. And by doing so, I will end up at the dashboard app, which is, the quick start for anyone working with data. And from the packages that we have just described and that Marek has referred to previously, I want to show what we have done here. So we start with the most important, with the data and its availability. So the dashboards that you see in DHIS2, they are well structured, and the narrative of each dashboard is logical and sectioned in its configuration. We have also added the terminology for the users to be able to see and help them guide through the dashboard. So let us start with the. I'll zoom a little bit. We have the 8 standard dashboards on for the TB surveillance. 2 for the notifications, the quarterly and the annual. We have the new dashboards for the drug resistance testing and results. Then we have the quarterly and annual dashboards for outcomes, and then a separate dashboard for laboratory and household contacts. In addition to that, we have some service dashboards with line lists that are more for the programs to use when it comes to tracking missing data and data quality and so on. So what we see on the dashboard is not a static picture, but it's a adjustable visualization of the indicators that were presented here earlier. Let's say starting with the notifications for the quarterly reports for new episodes of TB, where trends are followed by maps visualizing the numbers directly on the map. And we have the, as the data loads up and I scroll down, quite a big story, followed by the rates. So in the DHIS2, when we import the population data into the platform, we can compare our numbers with the population rates, followed by HIV cascade for the new episodes, and so on. Now, when I said that this is an interactive dashboard, so you can open each of these visualizations separately and drill the data down to the level where this data has been collected, and you can filter it also directly on the dashboard. Let's say if I change this subnational dashboard to a specific region, my numbers will instantly adjust to that particular region. And if I had data in this test instance on lower levels, such as districts, then this map would also be then divided into districts for this region. So the data is available, and of course the rights to access the data are configured within the system. Now, how does that data get into the platform? We have, for those implementations that enter data from paper registries, there's the aggregate data reporting data sets, which you can see here on the screen. So, for example, for the quarterly notifications in a specific facility or region and a specific period, we have structured sections where data can be entered, and that data will then later be aggregated to those dashboards that you have just seen. Now, if I run the implementation where we have the capacity to collect individual data, we also have the tracker. So here you can see the newly published TBK surveillance tracker, where in this demo presentation, you can see an individual record of a case of TB. So with the key data on the person, on the demographics, and so on, we also have the results on the diagnosis and notification of the data, risk factors, HIV data, and so on. But then also the diagnostic testing, the treatment episodes, monitoring results, and so on. And this version of the tracker supports the new guidelines. It supports the generation of the indicators for treatment and so on. Now, it is set up in a linear format, which will allow you to export the data basically as a register in a register-based format, and that will also allow you to import data either manually or automatically from other platforms such as electronic medical records, laboratory management information systems, and so on and so forth. And such trackers, such modules are already in use by many countries, and you will hear more about it today. So at this stage, I will pass on the floor to Stefano, who will show you the HIV case surveillance. Thank you.
Thank you very much, Yuri. If you can confirm if you can hear me well, please.
Yes, we can hear you, Stefano. Go ahead.
Thank you very much. Thank you very much, Yuri. So we'll start and cover some of the aspects that Yuri already shared before, and many information were already shared by Shona. So one of the aspects that were really central as well on the development of the HIV toolkit, but as well tuberculosis and many other toolkits that we are working on, is how we place this in the very complex scenarios of the different countries, which they are maybe using several different tools and several actors that are participating on this answer, especially for a program like HIV prevention, in which there is normally many national societies plus a civil society that are participating on this response. That's why the toolkit itself, they function as a standard and a reference configuration that can be placed within the life cycle of the data life cycle in several places, either for the data collection or either for the storage or as well for the analysis. That's why there are many components that are present on the toolkits. There is what was shown by Yuri for tuberculosis, the possibility to collect the data at the individual level, so using the DHIS2 for the data collection side. Specifically for HIV, there are two main programs that are the HIV prevention and the HIV case surveillance, as described by Sean, in which the same entity, the same person can be enrolled in both programs, starting kind of using the entry port as HIV prevention, so unknown or unknown HIV negative case, and then shift to the HIV case surveillance in case the case is then positive. There are some information, like very sensitive information related with the key population. Those information are not collected during the enrollment of a person, but are collected in a separate stage. This is to ensure the compartmentalization of the information and to maintain the highly sensitive nature of this information. So the patient in DHIS2, the client, they cannot be searched by this specific attribute, and those can be completely removed. The central stage for both HIV case surveillance and prevention are the visit. So this is really to replicate the patient-centric approach. So those data are collected every time a patient is accessing to a health service, to a health facility. And the way how it's been structured is that based on the activity that are provided in each one of the visited, you can just select and to be able to show, for example, if a risk assessment is done with a set of questions, if there was a condom distribution or HIV testing. Each one of them as well have their own specific date, as the different setup are not always the same. So, for example, an HIV test can be done in the same visit, or is referred and the test is done in another place. So this allow as well the data entry of from different type of users and location. So once the patient has been enrolled into the HIV prevention program, then maybe this patient becomes positive for HIV results, so need to be enrolled in the HIV case surveillance program. As you can see, I've just jumped from a program to another one. Means that this person, this patient, this entity is enrolled on both programs. We can achieve this through the creation of a relationship. And the information, of course, the personal information stay the same, and what is changed, the information that are collected on the different programs. So on the visit for the case surveillance, the key information is related with the treatment, of course, the treatment initiation, type of treatment, and then, of course, all the rest of the information relative with co-infection, tuberculosis, HIV, vertical transmission, STI, viral hepatitis, and or cervical cancer. Once those information are collected, of course, another capabilities and very strong capabilities of DHIS2 is related with analytics. So all the information that are actually collected into a tracker program, they can be analyzed, and the combination as well of many filters. The different toolkits that normally we produce with DHIS2, in this case for the HIV, comes with a set of dashboards, as was shown by my colleagues Yuri for tuberculosis. In the case for HIV, you can find the HIV case surveillance or the HIV prevention, or the most generic HIV that are representing the 395 targets for the specific for HIV. And those dashboards are either thematic dashboard, for example, for the HIV prevention, the one that are for specific for testing. So all the indicators that are useful and needed for the testing side, the PrEP, PEP, and others, and the same for the case surveillance. Case surveillance more generic for the treatment with all the indicators linked to them, epidemic status, STI, and etc. Beside the HIV as well, there are other two tools that have been developed, one specific on hepatitis. Of course, hepatitis information collected as well in the HIV program, but of course are related with those programs. But there have been developed as well as product on hepatitis, so generic, independently from the HIV status of the patient, and another one on STI as well. Here are two different dashboard, nationals and subnational. Subnational health facility based on the type of user that is accessing the system itself. Of course, in this case, what we have seen are analytics. So in case a country that is using, and normally 99% of the case is this, in which they're using several tools, EMRs, DHIS2, and any other tools, they will need to integrate this data into a platform. It can be used, and they can use the DHIS2 dashboard to be able to unify this type of information and analyze all of them. There is as well an aggregate data entry type of data model for HIV, hepatitis, and STI that can be used as a landing site for the information that are extracted and aggregated for different tools, or can be used as a primary data entry type of support. Just want to mention as well that both the HIV prevention, HIV case surveillance toolkit, they have been aligned with the most recent DAC that was published 2 years ago for the HIV, and all the metadata that are present, data elements, indicators, and an option set has been mapped with the DAC. And as well, the DAC was extremely useful and informative for the production of the different indicators to the DHIS2 system. Thank you very much.
Excellent. Many thanks to both of you, Yuri and Stefano, for this excellent session on providing a demonstration of the metadata packages for all available disease areas, and both in terms of packages that capture and visualize both case-based and aggregated level data. I will also say that we are looking into creating an account for this kind of demonstrations that can be accessed by others as well, and making that available. We are currently working on that. So this what you've seen now has been using the accounts of our colleagues at the University of Oslo, but we do realize that this could be quite useful and of interest to many of you out there who would like to play around with this as well. I should also add a disclaimer: the individual level data that you've seen are not representing an actual person. So these are dummy data. Just making sure that this is recorded properly and it's clear. Okay, so we are now moving on to, you've heard the methodology, the approach, the content. You've seen how these packages have been developed, what they look like. Let's now hear a case study. Let's now hear a case study of how these packages, and in this case it will be the aggregate level data packages, how they have been used at the country and rather the regional level. So we will be hearing from our colleague Casimir Manzengo from the WHO Afro region, in particular Western Africa. Casimir, the floor is yours.
Thank you, Babis, for the floor. Good morning, good afternoon, depending where we are now. It is a pleasure for me to present a case study of BBNT initiative, the contribution on data use. BBNT initiative is innovative SAF-to-SAF collaboration based on the data-driven approach to strengthening HIV/AIDS, tuberculosis, malaria response between Benin, Burkina Faso, Niger, and Togo. Slide, please. And what is our methodology is mainly on the peer country support between these 4 countries using the quarterly data review, the peer country visit, and experience sharing workshop. This is the launching led by the Minister of Health with the WR and the UNH country director. Slide, please. Focusing on the quarterly data review, we had 6 main steps. The first one, the program starts by the data extraction in the DHIS2 for HIV, TB, and malaria. And secondly, they go to check the quality. And after this, they go through the data analysis to see the time trend, the geographical distribution, and some specific population. And after this, they based on the cause, the root of the work performance, they take some decision, and they start in the country level to share between the 3 programs. HIV, TB, and hepatitis meet together to discuss on this. And after the national level, we organize now a workshop with a meeting, a call webinar with the 4 countries to share what are the fundings. This is what we are doing with the 4 countries. Slide, please. Concerning the use of DHIS2 in the national programs, we can say that for HIV, hepatitis, and STI now, they are all using the DHIS2. We make many efforts to focus on this. For TB, we are working with Benin to integrate also DHIS2, and malaria, of course, all the data are in the DHIS2. Slide, please. And what are the main achievements? We can say that we can summarize in 3. The use of peer country supports was very useful between these countries. Also, the data culture after this culture now is more and more effective in these countries. The country now are able to decide based on the data now. And also another thing is the subnational analysis, which help the country to prioritize and to take the precise decision when something is going wrong. Slide, please. This is a first example of the use of the coverage of WHO recommended rapid test in Togo. You can see that the coverage is a bit low at 71%, and they start with our support. They start to go through the regions to know where is the problem. And they found that it was in maritime, and in maritime they found what are the health facilities with the high burden of patients, and they organize now the health facility peer supports, and you can see that the last one, HIV, after sharing experience with Vaughan helped HIV to improve his performance in the next quarters. So not only the peer country support, but they go now through the region peer support and the health facilities peer support, which is a good thing. Slide, please. Here we have another example from for PMTCT in Burkina Faso. We can see the first slide. The testing is declining on the blue color, and the analysis made at the regional level, they identify that it is the region is where the issue is most the cascade, and in cascade we found that there is the Banfari where the Banfora was the problem, and going in the Banfora, you can see here with the data from DHIS2 that less than half health facilities providing PMTCT have been testing for this period. So the solution was just to focus on this district and to solve the problem, and we can increase the performance of testing. Slide, please. Yes. It is also a good story we are sharing with you. After Togo has had a weak performance on PMTCT for hepatitis B. You can see that in 2033, almost nothing were done. 0% of prophylaxis for pregnant women with hepatitis B. But after the sharing experience with Togo, here is the visit in Togo, and with Burkina Faso, they went back in the country and they improved their activity, and now we have almost all of the pregnant women who have been tested by for hepatitis B, and those who are positive are put on the prophylaxis. So it is a good case study, and we are now sharing this in the global report for hepatitis. Slide, please. We have some areas for improvements, like the discrepancies for viral loads between the HIV report and the DHIS2, and we are working on this to reduce this discrepancy. Also, we are now able to capture the data for screening and treatment for hepatitis and STI in the and syphilis in the DHIS2. It was not the case at the beginning. We are now working also to integrate the TB model in the DHIS2 in Benin, and we are working also to share all we have like best practices. Slide, please. Okay, our perspective is to see we are now planning to move from the 4 countries and go to 10 countries in West Africa using the same strategy and methodology. Also, we should strengthening the capacity to use the dashboard embedded in the DHIS2, because until now we are just taking extract data, but we should strengthen the capacity of our MNE to be able not only to see data but also to explore the dashboard to get all these graph I showed earlier. Thank you for your attention, and thank you for your attention. I'm available to respond if we have some question. Thank you.
That's wonderful. Many thanks, Casimir. So we have just heard a case study for how the aggregate level data and in particular the DHIS2 packages have been used both for across and within country action, how they've been used to improve programmatic efficiencies, to improve collaboration within countries and across countries. We are now moving on to other examples, and in particular, we're happy to invite our panelists. So Guy Stallworthy from the Gates Foundation and Michelle Monroe from the Global Fund. Can I please check that both Guy and Michelle are available? Yes, I can see them. Wonderful. Guy, I would like you to please share with us your experience and lessons learned with the implementation of the case-based DHIS2 TB tracker in Pakistan, and this is, I will say, this is probably the most ambitious implementation of a DHIS2 tracker in the TB world globally. Particularly since Pakistan is one of the highest priority countries. It is a country where we have hundreds of thousands of people diagnosed with TB on an annual basis. It is a federal system with federal level and provincial level, independence in data governance and collaboration. It is a health system that has a huge private sector, so it is quite complicated in some ways context to implement something like that, but it has happened, and it's been a long time coming. It is a process that many of us have really invested a lot of time and effort and funding in supporting the National TB program. So Guy, the floor is yours.
Thanks, Babis, and you can hear me, I hope.
Yes, we can.
Yeah, the context here was the Gates Foundation TB delivery team, of which I'm a part, had been supporting by around 2021, 22. We'd been supporting private provider engagement and the data systems in India for more than 10 years. And we had recognized just how important the case-based digital data system is for engagement of private providers because of the need to have an efficient system of recording and reporting that doesn't burden the providers. And we took a chance in 2020. We wanted to sort of extend that experience to other priority countries, and Pakistan at the time did not have a case-based system. And we had supported development of India's bespoke national system known as Nikshay that many people might be aware of. But we decided to see whether it could be done more quickly and at lower cost by working with the DHIS2 ecosystem and specifically the tracker, which at that time was fairly new and, as you said, had not been used at scale for TB. So for us, it was something of an innovative risk investment. We put together 3 grants totaling about 5.4 million over 4 years. One of them was to the National TB program, obviously to host and be the steward of the system and develop that capacity. Another was to the University of Oslo and the local HISP affiliate to provide some technical support. But we also gave a substantial grant to the 6 NGOs working under the Global Fund for private provider engagement. So we made sure that we worked with the same stakeholders, key stakeholders. And those NGOs led by the principal recipient, which is Mercy Corps, now called Prosper Global. And so Those grants became effective in 2022. They started by configuring, customizing the metadata package for Pakistan, piloting it on a small scale, sorting out all the problems to get it to function to the minimal necessary, which was essentially to generate the key TB reports, the 07, 09, at that small level. And then once that had been figured out, the progressive rollout nationwide, all the training and the user support, and then continuing adaptation and improvement. And as of last year, over the course of about 3 years, they successfully did this and scaled it up in both the public and private sectors nationwide, and it's now in complete use throughout Pakistan with over 2,000 users throughout the country and about 500,000 notifications per year. With the one exception that in the public sector in Punjab, they have declined to allow the interoperability and they're still using their HMIS, and therefore there's some double entry from that into the DHIS2 aggregate system. So that's what happened. The results have been quite good in terms of the efficiency gain. There are many benefits, of course, but the efficiency gain of the staff is one of them. And Mercy Corps presented at last year's union conference some research where the staff, a survey of about 455 staff, they estimated that they had saved each an average of 3.4 days per month as a result of the introduction of this system, which is about 18% of their total time. And extrapolating that, it's the equivalent of 158 additional full-time staff because they have around 900 field staff engaging the GPs. So overall, quite successful. I would highlight maybe 6 issues briefly. The first is the starting one that we felt it was very important to develop the system for the different use cases, and the private engagement is quite different from the public sector facility use context. In the private sector, not just in Pakistan, but many other countries, you have hundreds of field workers, in this case, 900 NGO field workers with tablets who are each responsible for 25, 30 GPs. You have 14,000 GPs. And they're supported in Pakistan by a call center. So that process flow is quite different, and it was important that the system and the dashboards and etc. be designed for both kinds of users. One of the key, and this is of course applicable to many other countries, and we're hoping it may be used in Nigeria, building on the Pakistan experience. One of the key challenges was you really need rigorous, consistent facility lists with the same identifiers used by all stakeholders, not just once, but maintaining that rigor over time. And they're still working through the connection of the tracker data with the aggregate DHIS2 because of that need to fully align thousands of facilities between the two systems. That's one thing to bear in mind from the beginning. That in turn highlights the need for really strong governance arrangements. There are many decisions that need to be taken with input from federal and national level, but also public and private users, and SOPs for those decisions, such as which indicators, how to modify the timing of reports, cutoff dates, etc. And so in a complex system like Pakistan, that was a bit challenging. And I mentioned already the reluctance of Punjab to allow its system to be interoperable. Obvious need to embed the capacity for all of this within the NTP, and it's not just, it's a never-ending capacity. These systems are never finished. There's always work to improve data completeness, data timeliness, data accuracy, and job aids and dashboards. So that's an ongoing need for technical capacity. And some of it can be in-house, and some of it the NTP needs to be able to contract local capacity for that support. It was interesting that program staff were very used to the old routine and sometimes have been reluctant to give up the quarterly paper datas and reconciled data, even though they have access now to real-time data. And then one of the challenges for the DHIS2 system was for the management of such a rollout, it's really useful to have user-specific metrics. And that the DHIS2 system had not been designed for, but the technical experts in Oslo were willing to support workarounds so that management could see dashboards at the user level. So I'll stop there, but a very, very rich experience. And as you said, pretty successful at the national level within 3 years. The job's not finished, it never is. And I hope that a detailed write-up of the experience of the different stakeholders in Pakistan will be published before too long. I'll stop there.
Many thanks, Guy. We will absolutely make sure that we can do as much as we can on our side to support the TV program in Pakistan to really share those lessons learned widely. A lot of very good lessons learned there, and also words of caution, of course. Right. So let's move on to Michelle now. So I'm sure everyone who has joined the call is familiar that the Global Fund has been supporting the development of digital tools and smart guidelines for several years at the global level, and of course their implementation at the national level. Michelle, could I please ask you to speak about Global Fund's objectives in supporting this work stream, what changes you have seen at the country level, and also how do you think countries can include this kind of request for supporting that implementation in their Global Fund grants? Michelle, the floor is yours.
Thank you, Bamis, and good afternoon or morning, everybody. So yes, the Global Fund, we've been supporting the development of these packages for DHIS2, for HIV and TB and other programs, as well as mentioned some in the presentation, the DACs and the SMART guidelines, the different levels. The DACs are one of the levels of the SMART guidelines. That are similar, that can be used for other types of software than DHIS2. And the reason we're supporting these types of packages for the software is there's kind of three main reasons. I would say one is that we've seen it saves countries money. Two is to have a higher programmatic and strategic information quality in the digital data systems in countries. And three, we heard a couple of times in the presentations that these really facilitate interoperability across systems. So I mean, some kind of diving into those three a little bit on saving countries money. This is something where, you know, a lot of the development of software and the configuration in particular is where, you know, the developers are working with a program and the program is defining how to get the program into the software for the developers. And while there's unique things in every country about the context, there's still a good portion of that, maybe 80%, you know, that's very similar across all of the countries. And these packages are basically, you know, taking the paper guidelines from WHO and others on programmatic guidance and also strategic information guidance and translating that into that software developer language and specifications, and in some cases, actual machine readable content. And so countries can take that and save a lot of money on, you know, just starting with that base and then customizing that base as they need to or want to for their country context. And again, that's either with the SMART guidelines or if they're taking the DHIS2 packages, which have basically already gone and implemented the SMART guidelines to create those packages. And so then countries are having that WHO program guidance more directly into their systems. It's easier to update as the packages get updated whenever there's new programmatic guidance, and then those can be updated in the country software systems. And at the same time, there's a lot of flexibility, of course, both in the DHIS2 packages or the SMART guidelines for other software. Countries can always adapt and customize the portions that need to be for their own context. And then just on that, the last piece I mentioned about interoperability, where we're seeing it's really important, no matter what the software type of system that you're using, to really be planning as much as possible. What are the standards that you're going to be using in your country from as early as possible, and building and developing and updating your software with those standards. And these packages are built based using those standards. And so it's a really helpful way to either adapt newly or to adopt existing software to those interoperability standards so that you have much more ready situation to be able to have your either case-based programmatic systems to be interoperable with your other logistics or lab or other data systems. In terms of ways that countries can consider this in terms of global fund support, I would highlight that this year and really these next few months are important time in the global fund cycle. It is the time period when countries are putting in their funding requests for what they would like funded for the next 3 years. So this is the time that the CCMs, the country coordinating mechanisms in countries, are having the dialogue in country to decide what will be put into those funding requests. And so if use of these packages or other aspects of your health information systems are things that should be considered there, you really want to be part of that dialogue, join the CCM dialogues and meetings, and bring these possibilities or things that you are designing for your systems in country to those discussions. This is a really key time period. Things can be updated over the time of the grant, but it's really much better to plan everything that's needed holistically during this time period. And so encourage folks to discuss with their CCM. The Global Fund website has information. If you don't know contacts in your CCM, the information is on the Global Fund website for everybody's, each country's country coordinating mechanism in country. I'll stop there. Thank you.
Many thanks, Michelle. I would now like to turn to Casimir once more and ask him about how he thinks, what are the key lessons learned and considerations from the implementation of this, of what he shared with us, with this regional approach. So for other countries, what should other countries that might be interested in using the DHIS2 packages in a similar way for their country, what are the key things they should be considering in terms of successful implementation, as well as what have been the key challenges? And before I ask Casimir to answer that, I would also like to give a bit of time to our Oslo colleagues to prepare an answer. We've had a number of questions around data security, confidentiality, and data privacy. I will be turning to them once Casimir provides to give an answer to that issue. Once Casimir is done with his response. Casimir, the floor is yours.
Thank you, Babis, for the interest and the question. We advise to use DHIS2 because DHIS2 is the national system. We can't continue to use parallel system in the current context. We should invest enough in the DHIS2 because we have the relevant data in the DHIS2. And this data can be shared with everyone. Even when we have at the level in the Ministry of Health, where they want to elaborate the report, the national situation, they use the DHIS2. So if the program is continue to use a parallel system, they will be out of the plan of the program. Another thing is the dashboard. We have when we use the DHIS2, DHIS2 can provide directly dashboard can help us to analyze, to discuss, and to show where is the problem. But I think that for me, the challenge we had at the beginning is that the program were not very keen to go through the DHIS2 because they are thinking that there is no the best thing. But after discussion, they saw that this is the best thing. Another problem is the number of indicators. Sometimes DHIS2 colleagues said that you have many indicators, HIV, TB, and so on. You have many indicators. What can be done? But now, after discussions, they become more and more flexible. So we need this permanent dialogue between programs and DHIS2 colleagues to see how to integrate the indicators from the vertical program. Thank you.
Very well. Thank you very much, Casimir. I will now turn to, let's see, Yuri. Do you have any initial comments? And then I will ask if Stefano has anything to add around the issue of data security, confidentiality, and data privacy with the DHIS2 packages.
Thank you, Babis. I will take the courage and answer the first question on the confidentiality. So the DHIS2 system is secure in terms of data protection, and the fact that it is, the data is always located at the place of the implementation where there's Ministry of Health and so on. So it's not an outside server. It complies with all the requirements needed for secure databases. But often the issues that we experience are the implementation itself and how the access is being given, the digital literacy, and so on and so forth. So a lot is dependent on how this is configured. But from our side, in the tracker program like that, where individual data is collected, it is fully protected from the outside by the system itself, by reverse proxy, and so on and so forth. So, and this documentation is available for users to access. And being part of implementations in different countries, we have, set this process of sending DHIS2 through cybersecurity assessments, through national assessments, and so on and so forth. And the fact that DHIS2 is used by European Union implementations and income countries, including Norway, already speaks for itself. So thank you.
All right. Many thanks, Yuri. Stefano, do you have anything to add shortly to this issue?
No, on top of what you already mentioned, no, not really. No, thank you.
Okay, so then I will ask Anne to provide her comment on this. Anne?
Yeah, thank you. Thanks. And just the two key points. One is related to what Kasimi said earlier. Thanks for leading this work. It's really important to see how it's done in the subnational level. But well, beyond the HIS, it's always important to link the programs and the HMIS system in the country, because we also need to look at it from the denominator side, look at it from, the health statistic perspective. And by doing that, we actually harmonize a lot of the work and help the HMIS in many countries based on the DHIS2 functions better. Secondly, is on the security. I think this is where it's not just the software. The DHIS is part of the EU network, so it only complies to all the EU requirements and regulations. But in country, it is important to look at it from the data management and governance issues. So data sharing mandates DHIS2 has function in that, but we also make sure that that is part of the data management in the country, and we should be able to support country to do that, to assign exactly the role and functions, and come without the regulation of security, so that the data is trusted to us, but also then we need to keep that trust as well, to make sure that only the right people have access to the right data, and particular for the case-based. So there are lots of recommendation on that, but this is a highlight for mainly is the work of the ministries, and more than Ministry of Health as well, that we need to look into that. Thank you.
Okay, wonderful. Many thanks for this addition, Anne. So checking also the questions, I think we have addressed all of them, either live during the presentations or through these responses that we have heard from the panelists and presenters. So what I would like to do now is provide a few closing remarks. I think in this environment of seriously reduced international and national funding for public health, we need to seriously look at streamlining approaches for the surveillance of TB, HIV, hepatitis, STIs, but also all other disease areas, and making sure that these speak to each other and they're part of the overall public health architecture. I think the time is gone where we had a lot of funding available to develop potentially multiple applications or to develop parallel systems, just as we were trying out the digitization of data. We now need to have very, very serious and close looks at what the data flows and patient flows are within a country, and make sure that we avoid any duplication in effort or the way that the limited resources are being invested in in establishing and maintaining sustainable routine surveillance systems for all disease areas. I will go back to the comment that Anne made early on about the principle of collecting data once and using it multiple times. We absolutely need to simplify as much as possible data recording practices at country level, at the health facility level, enter the data once, and then make sure that that data are available to all audiences for their purposes, that they're available to the clinicians for the management of individuals, they're available to the patients themselves, they're available to the district level managers or the national managers, or they're available for global reporting data. We really should be making sure that this is happening. And let me tell you, based on the experience that we've had with implementing TB epidemiological reviews over the last 10, 12 years in now more than 105 countries around the world, that is not the case. We know there is a lot of duplication that happens, and a lot of time and energy and resources invested into capturing data, the same data multiple times. So this is the first thing that we all need to look at very clearly. Then, of course, we need to look at the core indicators for specific disease programs. We heard about perhaps some of the complaints that are coming up, particularly from the higher level managers who don't necessarily see the importance of all these key programmatic indicators for specific disease areas, but they want to see some key, one or two key indicators for each of the specific disease areas for their purposes. So we also need to have nimble and purpose-built and concise surveillance systems to ensure optimization of existing resources. And then finally, we need to remember whatever we do in collaboration with the ministries of health and our member states and our partners and stakeholders, we need to be supporting the transitioning of funding for routine surveillance health systems, health management information systems overall, transition them from the international funding to national funding. And this has taken time. This has proven to be challenging in the past, but by explaining clearly how the systems are being used, we can convince governments and ministries of health to invest appropriately for everyone's good. All right, with those words, I would like to thank you all, participants, panelists, the administrative IT support, and our interpreters for being here with us. I thank you all and wish you a great rest of the day. Bye-bye.